Good evening, everyone. Welcome to the CSRS Education Society's webinar on technologies in the cervical spine. Our new platform is making surgery safer and more efficient. We'd like to thank all the participants for attending this very informative and interesting webinar. Our speakers tonight will be Dr. Michael McCarthy, Dr. Venu Nimani, and Dr. Sheeraz Qureshi. We'll be moderating Dr. Samuel Cho and myself, Dr. Sanjeev Sarotwal. As part of the CSRS, we'd like to encourage you to save the date for our next annual meeting, the 53rd annual meeting and 30th instructional course in Washington, D.C. This year will be held from December 3rd to the 6th at the Westin, Washington, D.C. downtown. We look forward to seeing many of you there. And for those who are not members of the CSRS, we encourage you to apply for membership. Membership applications are open from May 1st to September 15, 2025. And you can look online for further instructions. You can also connect with the CSRS on our social media platforms on LinkedIn, Instagram, X, and Facebook. Tonight's talk will be recorded and be available for future viewing under the webinars section of the CSRS YouTube channel. We also have cadaveric technique videos as well as topical presentations. We encourage you to look up the CSRS YouTube channel for further talks. For tonight's presentation, we will have the three different speakers talk about the various topics here, and we'll have a live discussion at the end, which we find very informative. Now that we have the Indiana representation, I pivot to the New York representation, have Dr. Sheeraz Qureshi from HSS, co-chief of HSS Spine, talk about utilization of robotics in the cervical spine.
Thanks so much, and thanks for having me. And yeah, I will do my best to represent New York. I feel like I'm already doing this in protest with, I didn't realize I had two Pacers fans. I've been tasked to talk about robotics and the cervical spine, and I'll do my best. I'm certainly passionate and involved deeply with robotics, but the field is quite young with regards to applications in the cervical spine. But hopefully this will leave people on the call thinking about what the options are. So most significant disclosure here is that I am a consultant and get royalties for Globus for their robotics platform. And I'm going to be talking a little bit about robotics in general, but specifically the Globus robot. Throughout at least my career, there's been a rapid expansion and now adoption of enabling technologies in the operating room. And if we think about where innovation in the last 10 years has come, it's less about the widgets and more about how we do things more accurately, more precisely, and more efficiently. And that can be seen with the utilization of technology in the operating room. So I think this webinar, specifically really useful for at least if there's young surgeons on the call who are thinking about sort of what's next. When we think about robotics, you really can't think about it without navigation. And I think all too often I hear people using navigation and robotics as if they're synonyms, and they're completely complementary, but not the same. And I would say the early iterations of robotic technology that I used, I wasn't ready to adopt, specifically because it was married to fluoroscopy as opposed to navigation. And I would say that the reason that robotics now in the current generation has been so successful with regards to widespread adoption has been specifically because of its marriage with navigation. But ultimately, similar to what you heard in Dr. McCarthy's talk, traditional fluoroscopy results in significant radiation exposure and can lead to less screw accuracy. And that's what really has necessitated the evolution of newer technologies, especially for those of us who have adopted minimally invasive and percutaneous techniques. Navigation, as you've already heard about, and I won't spend a lot of time on, is really in concept no different in the operating room than it is, when we're driving our car, with one major difference, and that is that there isn't real-time updates. And that's really, really critical when we're thinking about spine surgery, that we're working on a fixed picture, but the anatomy is changing at every moment. And this is especially important to remember when we're thinking about the cervical spine, where there's increased mobility between vertebral segments. And when we're using, whether it's robotics with navigation or navigation alone, you have to be able to understand what's happening in real time. So I am confident that with our industry partners, we're going to be able to solve this problem, but we certainly aren't there yet. I think Mike touched on this, but certainly the use of navigation has led to radiation reduction and has been shown to be able to be used without adding significant time demand and results in improved screw placement, especially with percutaneous screws. And in the cervical spine specifically, with regards to navigation, I think from a learning curve perspective, start using these enabling technologies in uninstrumented cases can be incredibly helpful when you're thinking about workflow and setup. And this case example of a patient with a C7T1 herniated disc, a case that I think is a great way to address this is a single level posterior cervical foraminotomy discectomy. And that can be difficult with regards to localization with traditional fluoroscopy, but with navigation, you can really get easy access, great visualization, and be really targeted. And these are the stepping stone technologies then that lead to the advancement of things. And that's where robotics comes in as the next iteration, using navigation as the basic platform and then adding the control of a robotic arm. So, in my opinion, what are the advantages? Why should we be thinking about adopting robotics, and why are so many people adopting robotics? It has to come with a reduction in radiation exposure greater than what we're already seeing with navigation. You need to have some improvement in the type of fixation that you're able to place. It should be good for the surgeon. It should allow to address certain surgical pathology that you may not otherwise be comfortable addressing. And you should be able to use it broadly in your surgery and not just for a single step. And then most importantly, it should be able to be used simply by everybody who's using it and not by just certain experts who are dedicating a lot of time to it. For me, robotics really starts with planning. This can be done the night before surgery or intraoperatively. This is just me planning a case in the operating room, and I like this time, spent with my residents or fellows who are in the operating room with me. We're talking about the different aspects of the case, why we've chosen to do what we're doing, different angles, what we want to think about facet morphology, et cetera. In terms of then placement of instrumentation, again, you can see here you've got the robotic screen, but we're working, excuse me, the navigation screen, but we're working through the robotic arm. And the robotic arm just allows to set a trajectory. That arm doesn't get tired, but at the end of the day, the surgeon is doing the work. In spine currently, the robotic arm is not entering the patient. I do like that the robotic arm can be used for multiple parts of a procedure. I like using it to hold a tubular retractor or set different trajectories for things that are sort of inclusive of an entire procedure. And we have found that this does influence, at least in our practice, the length of screws and the size of screws that we're using, which again, regardless of what part of the spine that we're working in, should lead to increased construct stability. And then importantly, the radiation dose we've shown further reduces. And you might look at these numbers and say, well, okay, you go down from 25 seconds to 20 seconds, or from 40 milligray to 38 milligray. But because radiation is a cumulative impact over a lifetime, any amount that you can reduce is going to be a plus in the long run. So why would we think about robotics in the cervical spine? So I think we'd all agree, when we think about fixation in the cervical spine, we're thinking about lateral mass screws or pedicle screws. Lateral mass screws are certainly something that I would imagine everybody on this call is very comfortable with. We think about them as safe with regards to the spinal cord and moderate risk with regards to the vertebral artery. Pedicle screws are more challenging. Obviously they're relatively commonly used at C2 and C7, but in the subaxial cervical spine, there is a significant risk with regards to spinal cord and the vertebral artery with the placement of pedicle screws. And very importantly, the pedicle morphology can change from patient to patient and even from side to side. So why would we think about it then? Why would we even consider placing a pedicle screw? Well, pedicle screws are clearly stronger than lateral mass fixation. And in general, for a majority of cases, lateral mass fixation is adequate. But in a case where you may be dealing either with patient-specific pathology where there's bone density issues, or if you're trying to save levels in terms of fusion and to shorten a construct but still want significant construct stability, that's where the ability to place cervical pedicle screws can come in very handy. So we, thanks to CSRS and through a research grant, looked at a study, which was a cadaver-based study to look at accuracy, precision, as well as systematic error with regards to cervical pedicle screw placement using robotic navigation. And what we wanted to do is we wanted to assess all three of these things. We wanted to say, is it accurate? Is there precision? And then if there's error, what is that error? So the rationale for our study was, can robotic technology ultimately be used to accurately place cervical pedicle screws? When we looked at accuracy, precision, and error, we looked at it with regards to or with consideration of what the FDA wants robotics to show. But specifically, we wanted to be thoughtful with regards to what the needs are in the cervical spine specifically, to be able to better say that these screws can be placed safely. So we did our analysis in 3 dimensions when we looked at accuracy, precision, and error. We looked at screws with regards to craniocaudal, mediolateral, and anterior posterior position of the screw. And we looked at these areas at 3 different positions of the screw, at the tail, at the mid pedicle, and the tip. Obviously understanding that the most important areas are going to be the mid pedicle and the tip, because that's where the neurovascular structures are most significant. Our hypothesis, we stuck with the accuracy, precision, and systematic error numbers as are required by the FDA for robotics. But you may look at this and say, well, I'm not comfortable with something just within 4 millimeters, especially in the cervical spine, because that's too much error. This was a cadaveric study, like I said. We used 3 cadavers, 30 total screws. We had done a power analysis showing that a minimum of 23 screws placed would be required in order to be able to show statistical significance. We were able to place 30 screws. What we specifically did here was we performed a preoperative CT scan on these cadavers. We then planned the preoperative screw trajectory, and then we transferred that preoperative plan to our robotic platform. This was done open, not percutaneous, so a full dissection of the cadaveric specimens was performed. The heads were stabilized in a prone position or taped, and then we used a spinous process clamp in the upper thoracic spine, and then used robotic navigation in a standard form where we burred, we used a drill, a tap, and then ultimately screw placement. We then performed a postoperative CT scan. We had previously validated a model using computer vision to be able to place sort of on 2 different CTs the planned trajectory with an overlay of the trajectory of the actual screw, and then determine accuracy, precision, and error at the 3 positions that I described earlier. This is the post-operative imaging. You can see all 30 screws were placed. This image essentially shows that overlay using computer vision algorithm, green line being the planned screw, red being the actual screw. And as you can just see here visually, good accuracy with regards to placement of planned versus actual. With regards to the actual accuracy, precision, and systematic error, what we found was with regards to accuracy, you could see that at the mid pedicle and tip, we were at 1 millimeter or sub-millimeter error. With regards to precision, again, at the mid pedicle and tip, we were at sub 2 millimeters. And with regards to systematic error, what we found was that when there was an error, it was that we were a little bit lateral and a little bit low compared to the plan. But again, this was sort of looking at what the likelihood, if you were going to miss, which way the screw may miss. Now, this information in a vacuum is meaningless, so we decided to sort of try to understand what this meant compared to information that we know about using enabling technology in the thoracolumbar spine and also doing placing thoracolumbar screws freehand. And what was very surprising to us was, and again, this is just a single cadaver study, so by no means am I saying that this is absolutely conclusive, but this study suggested that the placement of robotic cervical pedicle screws, at least in these cadavers, was not just as accurate, but actually more accurate than what other studies have suggested as well placed and safe and accurate and precise freehand navigated and robotic screws in the thoracolumbar spine. Certainly, the obvious limitations of a cadaver study, as you could imagine, with regards to spine mobility and not having stability, which would potentially lead to even more error, and obviously just a single study. But what we did realize was while we set out to say, could we place pedicle screws safely, we ultimately said, we can certainly talk about accuracy, but safety is a separate issue. And when we think about sort of the likelihood of breach, what we realized was that the only thing that we could say with regards to safety is that the bigger the pedicle, the less likely that you are to breach the pedicle. But safe with regards to safety as a surgeon, you have to take everything into account and really understand pedicle size and morphology when you're thinking about safe screw placement. But at least with regards to the plan and then sticking to the plan, we were able to show in this cadaver study that robotics and navigation together can be a powerful way to accurately and precisely place cervical pedicle screws. So in wrapping up here, where do I see robotics making an impact? I think certainly as we work with our industry partners in thinking about posterior instrumentation, especially in the upper cervical spine, C1 lateral mass, C2 pedicle, but also in the subaxial spine. And as we think about not only doing more complex cases, but also as we try to do the simpler cases in less invasive ways. And the good news is that a lot of our industry partners are starting now to make instrumentation handles, both for screw placement and for taps and drills, to accommodate percutaneous placement through a robotic arm. The other thing that I just want to highlight here for CSRS members is, especially the younger members, is that if you look at clinical data on robotic use in cervical spine, I could only find one study. So this was a study looking at 88 cervical pedicle screws. Their conclusion was similar to our conclusion for our cadaver study. But this is a real opportunity for the members of our society to sort of say, hey, you know what, we want to take the lead in this. And for anyone interested in sort of finding a place where the future may be, I think the thought of how to properly use robotics and navigation in the cervical spine certainly is an area that is understudied. Some unique considerations for the cervical spine. I know Mike mentioned most of these, but anytime I'm doing either navigation or thinking about robotics in the cervical spine, patient positioning, where the reference frame is going to go, accuracy. I always do an intra-op CT as opposed to fluoro to CT merge in these cases, because all of those things are going to matter, and your room for error is essentially, you should think about it as close to zero. There is definitely a learning curve with the cervical robotic navigation that I think is a little less steep than the lumbar spine, meaning that it's a little harder, takes a little longer, and there can be some workflow complexity greater than in the thoracolumbar spine, just with regards to positioning and things of that nature. But ultimately, somebody's got to accept the learning curve. And I think anytime that whether it's robotics or any of the technologies that you've heard about tonight, I think figuring out what works best in an individual's hands. Not all of these technologies are going to be equally translatable to everybody. But the goal of these technologies is that for the majority of users, it starts to level the playing field with regards to the hard skills of placing screws and things like that. The soft skills, like Mike talked about, make all the difference with regards to indications and and patient expectation, but let patient outcome be the main driver when it comes to all of this. Thanks so much, and let's go Knicks.
Thank you, Sheeraz, and I'd like to thank all three speakers for their outstanding talks on emerging technologies in the cervical spine. Now the session is open for Q&A. If you have any questions, please type it in the chat box, and we'll try to address some of them. And by way of starting, I'm going to ask all three speakers on the topic that they actually had covered, and that is the mobility of the cervical spine. The number one question is, how do you stabilize the cervical spine when you're positioning it? And number two, intra-op, I think Dr. Numani had mentioned he likes to use the burr instead of pushing on the cervical spine because of the mobility issue. How do you deal with that? So how do you immobilize the cervical spine? You use
Sam, I could start there. It's a
yeah.
what so specific to me, and I'm sure Mike and Venu and others have their own ways, but I instead of using a Mayfield or Gardner Wells tongs, I'll use a face positioner, similar to what you might think of somebody, a face holder that you might use in the cervix, when you're doing a lumbar case. I do find that that results in even more stability of the cervical segment than a Mayfield does. And then I am pretty liberal, even if I'm working with navigation or through a robotic arm with the use of fluoroscopy. I think it's a great place where you want to sort of use everything in your armamentarium as far as imaging goes to ensure that you have accuracy. And I haven't yet done robotically placed percutaneous pedicles, screw fixation in the cervical spine. Waiting to take the leap on that one, but at least in an open case, I'll still have the C-arm sort of draped in, and then have the face and the neck in a face holder, tape on the head, so that you get as much stability as possible. But even with that, there can be movement. What I find is that setting the trajectory and the starting point sometimes can be of greatest benefit, and then just kind of staying within those angles. But it's something that you need to be cognizant of the entire time.
Yeah, so I also do something similar. I don't use the face pillow, which is a good idea, but I also use a Mayfield. I think for some of the technologies where you have to register to an intraoperative CT scan and then you rely on the frame not moving the entire case, I think it's super important. One of the potential benefits from some of the other technologies that I talked about is there's less of that reliance on not bumping the frame or movement, because you can just re-register very, very quickly. I think also with 3D printed guides, for example, again, because they're segmentally based and they sit on the posterior elements of a single vertebrae, then there is no chance for shifting. However, one unique thing that can be an issue there is if you position the spine in lordosis, or meaning an extension like you might in a Mayfield, if you want to just set the alignment before you start, the guide can actually have interference from the adjacent facet joints because they're shingled, or even the adjacent spinous processes. Because the design of the guide is based on their position in a CT scanner, and sometimes you might have the head, with a bump behind it or something like that. So you have to be mindful of that. So there are some nuances from a positioning standpoint that can play a role in this. If I'm using 3D printed guides, I actually usually position the spine in Gardner Wells tongs in flexion. That way there's less interference from the adjacent anatomy, and then I'll just use bivector traction and then place the spine into extension when I'm dropping my rods and locking in the final alignment.
The way I tend to think about it, Sam, is once that spin occurs, an intraoperative spin, it's kind of like a nuclear isotope. It's going to decay. How rapidly that decay is happening, it's difficult, but I think especially in the cervical spine, you have to be acutely aware of that. So I tend to think that as soon as I capture that, that's the most perfect information I'm going to have. It's all going to slowly become more and more inaccurate. So I will Wherever I've clamped with, that's again typically C3 or C2, I then go and do my furthest segment away. So if I'm going to instrument T1 or do any cervical pedicle screws, I go furthest away and then work my way back up towards the reference array. Again, always thinking of time and distance as the enemy. So time from spin and then distance from array, right? Those are two things I always kind of beat into the fellow's head, is those are their enemies.
Thank you. Those are very useful answers and very helpful tips as well. Dr. Wilmer from Godoy thanks us for the excellent talk. And there's a question about changing alignment during the case to provide better lordosis.
So
Anyone want to?
yeah, I could start there. I'm sure everybody, I use an old trick that I'll place a IV pressure bag under that same face pillow, and then right before, after all the instrumentation is in, I'll have somebody squeeze the bag, which allows, sort of this improvement or restoration of lordosis. Take an X-ray, see what that looks like, and then place the rods.
Yeah, I use so in a flexible spine, I think that placing the placing the patient's head where you want it, getting an X-ray and making sure you're happy with it, I think works well. For some of the more severe deformities, I will often use Gardner Wells songs, or if you have it a pneumatic Mayfield, where you actually have control of the head through the drapes, and then you can adjust the head position intraoperatively, although realistically, sometimes it's a little hard unless you have the drape that comes with it. It's hard to grab the handles and actually adjust it. So I'll often have an assistant or one of our PAs or even a resident or fellow get under the table and manually manipulate the Mayfield and the patient's head while you bring the head up with the pneumatic head holder. And so there are some tricks there. The other things that you can do is intraoperatively, if the posterior elements are still intact or the spinous processes are still intact, you can use Atlas cables around the spinous processes. And as you tighten the Atlas cable, that will bring the spinous processes closer together. You can also use a penetrating towel clamp to essentially squeeze on the posterior elements, and that because it's a fair bit posterior from the center of rotation of that individual vertebral segment, that can also generate lordosis as you then tighten your set screws and lock down your rods segment by segment.
Great. Thank you very much. I think it's already 9:01, so this will bring us to the close of this webinar. So this will be uploaded in YouTube. So join the YouTube channel for CSRS, and then look out for the next webinar. Thank you, everyone.